Good morning from Miami. This is Dr. John Bennett broadcasting for the Neurosurgical TV online conference. And today we have the pleasure of having Dan Ochieng, MD, a neurosurgeon from South Africa. This is Dan's second appearance on the program. We welcome him. And we also have some members of the panel. We'll introduce them first before we turn it over to Dan. We have a new arrival. Rakesh, could you please introduce yourself?
Hi, I'm Dr. Rakesh AV. I'm from Bangalore, India. I'm aspiring neurosurgeon. Nice to be in the team.
And he just finished his boards. It's a big day for him.
Yeah.
Big day for him.
Yeah.
Congratulations. And Simon, welcome.
Thank you.
Well, thank you very much for allowing me to be part of this panel. I'm in Tokyo. I'm also a neurosurgery enthusiast, a medical student at the moment, and a developmental psychologist.
He's always a plus on these panels. And Slaven.
Thank you.
Okay, we're having a bit of an audio thing. But okay, Dan, welcome back, and it's all yours.
Hey, thanks, John. Today, I'll be talking about epidermoid and dermoid cysts. Very basic talk, nothing fancy, unfortunately not too many surgical videos. But it will just be a primer for maybe what we can go into detail into the next talk. So when it comes to dermoid and epidermoid cysts, they're generally developmental condition, usually benign tumors that can be found anywhere in the body, but I'll focus, since it's a neurosurgical presentation, I'll mainly focus on them found within the within intracranial or within the head and neck region. And consensus generally is that they arise when the ectodermal implants are trapped. You remember during the embryological period, during the week of 3s, during gastrulation, the 3 germ layers form, and as the embryo then folds over, then occasionally some of the ectodermal crests are trapped by the 2 fusing ectodermal surfaces. And as we can see in this diagram here, this is the week of 3s, and you have the 3 germ layers, and as the 3 germ layers then fuse, then occasionally you might have some rest forming there.
Excuse me, Dan, your PowerPoint's not showing now.
Oh, okay, cool.
Yeah.
Same mistake as last time. Sorry, looks like whenever I go to the large view, then it doesn't move. But when I have it on the smaller view, then you're able to see that, right?
Okay, well, just do the smaller view then. That's fine.
Okay, then I'll do the smaller view. Okay, that's fine. Anyway,
and could you
sorry
move
about that.
Okay.
So anyway, back to just to recap the introduction. I just said that generally they're mainly developmental tumors, and they generally arise from a problem during the folding stage of the embryo. And some of the ectodermal implants, then usually when the embryo is fusing, then you have some ectodermal crests that are then trapped. And therefore you find that ectodermal appendages, things that would end up forming things like skin, fat, hair follicles, and stuff like that, then later on are trapped either within the brain or within the skull itself or within the mesoderm that goes on to form the coverings of the skull. And then this later on develop into either dermoids or epidermoids. It's important to note that because these are benign tumors, then generally they have a linear growth rate. And they grow at sort of a determined period. It may vary from individual to individual, but generally the plan would be a linear growth rate plan. Even though I'm covering them together, there are certain subtle differences between epidermoids and dermoids in terms of their epidemiology, their locations, and any associated anomalies.
Excuse me, Dan, I'm sorry to interrupt, but your slides aren't showing it. No.
Really?
No, they're not showing. I'm sorry to interrupt.
Oh, sorry about that. Let me do that again. Let me share again.
And please, could you tilt your camera up? But we can only see the top part of your head. Okay, we'll see the slides. I'll let you know if you can't see them. Okay.
Sorry, it looks like there's a lot of technical hitches today.
That's okay. We'll get it.
Cool. Anyway, so when it comes to comparing epidermoid and dermoid tumors, so generally there are subtle differences between the two, even though they may arise in the same way. Epidermoids are generally more common than dermoids, where they form between 0.5 to up to 1.5% of all primary brain tumors, as opposed to dermoids, which are a little bit more rare, forming about 0.3% of brain tumors. In terms of lining of these tumors, then the linings of epidermoids are usually stratified squamous epithelium, as opposed to dermoid cells that usually include other dermal appendages and may include things like hair follicles and sebaceous glands. The products of these two lesions are slightly different, with the epidermoids having more keratin, having more cellular debris, more cholesterol, and occasionally, very rarely, they might have some hair. But hair and sebum is more common in the dermoids because they come from that mesenchymal origin. In terms of location, the dermoids are usually more midline. So I'll show you a couple of pictures where you find them all usually within the midline. If it's on the surface of the skull, they're usually either around the superior sagittal sinus. If they're intracranial, then usually in the paracellar region, as opposed to the epidermoids that usually tend to be more off the midline, more common in the lateral aspects, especially the CP angle. But also you can find epidermoids in the midline, especially in the fourth ventricle. In terms of associations, epidermoids then also tend to be more isolated lesions as opposed to dermoids that then usually associated with other congenital anomalies, as we'll come to see. And in terms of meningitis, then the types of meningitis between these two are usually associated with these two are usually a little different. The epidermoids usually give you a recurrent aseptic meningitis, also called Mollaret's meningitis. While the dermoids usually, because it's associated with the surface, then there are repeated bouts of bacterial meningitis because of the ability of bacteria to be able to access the central nervous system. When it comes to in terms of location, as we've said, epidermoids can be off midline, cerebellopontine angle being the most common, 40 to 50%, but again can also be found with the midline. This is as opposed to the dermoid location, which we've talked about, which is often midline, can be in the paracellar region or in the frontobasal region, and also occasionally ventricular. Dermoid are also known to rupture quite a bit, and post-rupture, then you can find all these fatty materials spread within the ventricles and also disseminated within the subarachnoid space. In terms of how they look like, the clinical presentation will generally be dependent on where the lesion itself is. I have a couple of pictures here showing especially dermoids. You can notice that all these are in the midline. It's usually a bump. It usually contains multiple layers on the surface, and when you open it up, then you may be able to see keratin. Sorry, you may be able to see sebum. You may be able to see hair and other dermal appendages. If these lesions are intracranial, for example, epidermoids, those that are within the CP angle, then the presentation will depend on the associated structures that are nearby. So in the CP angle, then you have your 7th and 8th cranial nerves. So these patients may present with, for example, facial nerve palsy on one side. They may present with a sensorineural hearing loss. If the lesion is quite large and is pressing on the brainstem, then they may present with some kind of a hemiparesis or hemiplegia, or if it extends upwards, then they may also present with compression of the trigeminal nerve, giving some kind of facial paresthesia or facial numbness, depending on which of the branches of the facial nerve it affects. If it's within the spinal canal, then again, the presentation may be either with some kind of radiculopathy or with some kind of myelopathy, depending on, again, the degree of compression of the spinal cord. In terms of radiology, we don't use X-rays very much. MRIs is the gold standard for diagnosis. I've just included some plain X-rays, especially for those who come from resource-poor settings. And for example, someone comes in with a bump on the head, and you just want to know whether the skull is intact or whether the lesion goes in intracranially, then a plain X-ray is something that you can use. For epidermoids, if you use a plain X-ray, then usually at times you can see a solitary lesion as seen in the X-ray on the left. They usually tend to have a sclerotic border, and usually there seems to be some kind of intradural extension. This is as opposed to metastases, for example, that might look the same but are usually multiple and are usually a mixture of either sclerotic margins or may also have blastic features. In terms of CT scans for dermoid and epidermoid lesions, then CT scan is best for the ones that affect the bones. So it's best for intradiploic lesions, and these show sort of well-corticated lesions as seen on the image on the right. When it comes to general CT scans of these lesions, they're mostly either iso-intense or hypo-intense. This is unlike the picture I'm showing you on the right side of the image, which is a hyper-intense lesion. The reason I showed this is because it's very rare you can find epidermoids also appearing as hyperdense, and this is usually if there's a high fat content with them. This will be only in about 3 to 5% of epidermoids. MRI, however, still remains what is the gold standard for detection of epidermoids and dermoid tumors. And generally, if you look at the image on the extreme left, that is a T1 weighted image with the contrast. Usually, you do not need contrast, but on the T1 weighted image, you know it's a T1 because of the fact that you see that the CSF, especially in the ventricular space, the CSF is dark, as opposed to the T2 images where the CSF is bright. On the T1 image, then the lesion usually looks either iso or hypointense, while on the axial T2 weighted image, then the lesion looks hyperintense. This, however, can be similar to other lesions, for example, even arachnoid cysts. And therefore, a way to differentiate your epidermoids from arachnoid cysts is to do a diffusion-weighted sequence. Diffusion-weighted sequence usually checks for restriction within the lesion. And if there's restriction within the lesion, then the lesion will appear bright. And on the image on the right side, you can see that there's diffusion, there's restriction, and therefore the image appears bright, and that confirms that it is an epidermoid cyst. And just to show other images, again, something similar, this one is just to confirm to you again that even though I told you earlier that epidermoids are usually off-center, you can still have them presenting in the midline. So the image at the top is a sagittal cut. It's a T1 weighted image. And again, you can see a hypointense lesion in the sellar parasellar region, mainly suprasellar region, extending to the base of the frontal lobe, and it's hypodense, and it seems to have or seems to occur in lobules. When you look at the image adjacent to it, if you go clockwise on the image adjacent to it on the top right, then you see on the on the T2 weighted image, then it looks bright. And on that, because of its position, you can see the middle cerebral arteries are encased within the lesion itself, and it sort of encases them, and it's difficult to pull them through that. If you look at the bottom image on the left, it just confirms the same thing, while the image on the bottom right is the diffusion weighted image, which shows restriction and again shows brightness. And that is basically for epidermoids. When we go to dermoids in terms of imaging, CT scans are very common, and for us, that's what we use typically to diagnose most of the CT scans. And when you look at it on a CT scan, they usually have a fat-like consistency. They're usually well delineated, and up to 20% of them may be calcified. The image on the right side, again, is an axial CT scan. You can see the midline lesion. It is hypodense in nature, what you'd expect of fat. And if I forget what fat looks like, usually I try to look at the subcutaneous tissue, and you expect the subcutaneous tissue to be fat, and then you can see that it has the same consistency as what you'd expect in the subcutaneous tissue. There's some calcification around this lesion, and all these white dots, for those who don't see a lot of CT scans, and that would be what calcifications look like. MRI scans, again, for dermoids are still also the gold standard. And the thing to notice about dermoids is that their presentation or how they look on MRIs is even more variable than how epidermoids are. And generally in T1, they are hyperintense, while in T2, they are usually also hyperintense, but this can change. The reason why there's a lot of variability in how dermoids look like is because it depends on what the level of fat or triglyceride content within it is. And therefore, even in one epidermoid, you can find different consistencies of the fat level or the triglyceride level itself. And therefore, you can at times even be able to visualize or see fat fluid levels within the same lesion. Usually, if you try to do some contrast, usually there's no enhancement. And as we mentioned earlier, there is possibility of dermoids rupturing. And if they rupture, then you will see this fatty material going all through the ventricles or within the subarachnoid space. Some images to show how this looks like. Again, from left to right, on the left side, we have a CT scan, a hypodense lesion with some peripheral calcification, the white material on the side. If you look at the T1 image, you see it's hyperintense on the T1 image with the brightness on it. And that usually confirms to you, if you find it is a hyperintense on both T1 and T2, then it's most likely a dermoid cyst. So in terms of management, again, I'm just about to wind up. I don't, unfortunately, do not have enough time to include some surgical videos. But generally, we say these are benign tumors, and therefore microsurgical resection is the gold standard of care. And basically what you want to do is to try remove as much of the tumor as is safely possible. The approach to the tumor will depend on its location. For the epidermoid tumors, especially the ones that are either in the CP angle, then the most favorable approach that I use is usually a retrosigmoid craniotomy with the patient positioned prone, having marked the region of where your transverse sinus is and where your sigmoid sinus is. Some of my colleagues have preferred to operate on these patients either in a sitting position, but I just find that there are a lot of complications, and then I have to usually monitor for possibility of air embolism and all that stuff. So I prefer to try get the CP angle lesions from a retrosigmoid approach. And the main thing, once you're able to do a lateral craniotomy, then you're able to just be able to see where your cerebellar tonsils are, and you're able to get a nice corridor to take you all the way to the CP angle. With the main thing to remember is that because these are soft tumors, then most of the cranial nerves are enveloped around it, and therefore you have to make a you have to be careful in trying to resect as much as you can safely. Some people would use monitoring in order to be able to prevent or to be able to tell you when you're pulling a little bit more on the nerves, and therefore to prevent injury of the nerves. But because these tumors, at times, if you cannot get all of it, you'd rather be safe, leave some of the tumor behind. Yes, it might recur, but then you might have, you'd rather have a patient with a minimal deficit and maybe operate on them maybe another 10, 15 years later if there's recurrence. Because there's no role for, because they're benign tumors, again, there's no role for radiotherapy or chemotherapy in these tumors. And you just have to try to get as much surgical resection as possible. Complications is something that we really try to avoid, but just like any other operative procedure, we need to watch for the possibility of infection. We need to watch for the possibility of bleeding. We need to watch for the possibility of injury to nervous tissue, especially if they're within the fourth ventricle. It's very important to try to protect the flow of the ventricle, fourth ventricle, if you can. And for example, if the patient is positioned well, if you can get cottonoids or patties early during your dissection and be able to protect the flow, then that's something that I definitely advocate for. It's important to warn the patient about the possibility of them having some temporary swallowing difficulties if the nerves, especially the lower cranial nerves, are involved. And molar meningitis that we talked about, especially for epidermoid tumors, because they cause some kind of a septic meningitis, is also something that I tend to warn a lot of my patients, just to be aware that these are some of the complications that could happen. And yeah, John, that's generally a brief overview of epidermoid and dermoid tumors. And over to the rest of the panel if anyone has more contributions to add.
Well, Dan, thank you very much. Another excellent presentation, and thank you for staying up after being on call for 36 hours. I don't think I want people to realize, you know, the generosity and dedication that you have to come here today. And as we usually do in these type of panels, we defer to the neurosurgeon first to have any questions or comments. Hello, Rakesh, do you have any questions or comments for Dan?
It was a very nice presentation, Dr. Dan. Brief, yeah. Would you tell, I've always wondered about this sitting position and air embolism, so, and monitoring. So have you encountered, how many cases have you encountered, and how difficult was it to manage air embolism in sitting position?
So I've been lucky enough not to see any case of air embolism. It's one of those things you want to know about, but you never want to experience. But generally what we do is preoperatively, we especially need to screen for atrial septal defects, just because if they have an air embolism and it could go to the opposite side, so they get an ECG, get an echocardiogram. Intraoperatively, then we try to make sure that they have and transesophageal echo to be able to monitor or be able to detect any air embolism early. The main thing is usually prevention if you can, but then if you ever see in that position, you always prepare. I always tell my assistant or whoever is working with me to make sure that I have a lot of saline to irrigate the wound if I venture into a sinus, to make sure that I can lay patches on it as soon as possible. To try, those are the times whereby, in as much as you worry about your infection, your best friend is your finger. And if you ever see a hole in the sinus, you want to make sure that you put your fingers in as soon as possible. And then I also preemptively try to make sure that we get sort of a Surgicel cigarette to be able to put and wet it in, and then maybe later on you can try flap Dura on top of it. But I understand it's one of those things that I haven't experienced so far, but it's definitely one of those things you never want to get into a situation like that.
Okay.
Okay, thank you.
Simon, do you have any questions or comments?
Yes, please. Thank you very much for your presentation. And I can tell you, as a student, I'm actually in a radiology rotation at the moment, and I was intrigued where you were discussing T1, T2, and diffusion weight imaging, etc. And I tell you, I'm always confused by these points. Do you have any advice on how one can get used to finding the difference between these? I mean, I've been doing this for a long time. I still have difficulty telling the difference between T1 and T2, etc.
So general principles, not always, but the first thing I try to look at for MRIs is to try to look at the CSF. So the CSF is usually dark in T1 images, and also it's bright in T2. That said, the variation comes in when now you have other sequences, like, for example, a flare. And a flare is basically a T2 image where now you've nulled the CSF so that you're able to see more around the ventricles, and you don't have that signal affecting what you view. So basically a flare or fluid attenuated inversion recovery sequence tries just to show you the lesions a little bit better. The other thing, apart from looking at CSF, because the CSF changes and that might be confusing, is to look at the gray and the white matter. So the way I remember it is in T1, the gray matter appears gray and the white matter appears white. So the way it's called, so the gray matter appears gray and the white matter appears white. While in T2, then it's reversed. The gray matter now appears whitish, and the white matter appears grayish. Yeah.
Thank you very much.
Yeah. So that's the only way I try to remember it. And then in terms of just what you look for, it's always just important to remember T1 is very good for normal anatomy. So it shows you the structures very well. For example, if you're planning a resection, you want to see where the blood vessels are. You want to see how the gyra and the sulci look in relation to your lesion. But if you're looking now for the pathology itself, then the T2 shows you pathology better. It shows you edema a little bit better, and that's also some of the tricks that I try to use, Simon.
Wow, thank you very much. It's very helpful.
Yeah, I'm sure we have a question from a neurosurgeon in the making, Slaven.
I'll try to ask like this. Can you hear?
Okay, yeah, let's try it.
Thank you. Very nice. You're a great presenter, I can tell, and I was enjoying it. Can you please comment how often do you use sitting position, and what are the other positions of the patients that you use, and which one do you prefer of them? Thank you.
So I mentioned just briefly that I prefer the prone position, and that's just, unfortunately for some of these things, there's no randomized control trial that will tell you one position is better than the other. It's how you've been trained and who you've trained under and what is most common. So just for me, because I also work with a lot of children, then the prone position is what I prefer. I prefer the fact that I'm able to position the patient. My hand is at times able to rest on the patient, and I don't have my hands hanging out and getting tired the way the sitting position does. That said, the problem with the prone position is that if you bleed, then most of the bleeding usually goes into the field. And at times you have to try angle the table a little bit, but still you end up doing a lot of suction, and you really have to be meticulous in your dissection so that your field does not get really dirty. Other positions that some of my colleagues use, I've used only once or twice, is maybe a lateral decubitors, or maybe the modification of a concord. But again, the best advice I ever got from one of my teachers is pick one position that works best for you, and if you repeat it every time and time again, you get good at it. In terms of the sitting position, the time that I've used it is mainly when I've been assisting maybe in a pineal region tumor, and then if I want to get a supracerebellar approach, supracerebellar infratentorial approach, and the tent sort of slopes a little bit on the lower side, and therefore I have a huge gap between the inferior occipital lobes and the supracerebellar region, then maybe at times I'm forced to think about the sitting position. But again, with all the precautions, it takes time to set up and all the air embolism issues. But it's very good for exposure, especially when the cerebellum drops down and you have a very nice corridor.
Yes, Professor Florian from Romania is a great user of this approach, sitting position. Mm-hmm. So he says that the blood flow going down is one of the he actually said this, that the tentorium slows down. Mm-hmm. Then you have a clear view. So it's kind of universal. So thank you for your thoughts and your experience.
Thanks, Slavin.
Yeah, and Dan, the Slavin's a student. he loves his neurosurgery. I have a quick question, Dan. They certainly look very nasty on the CT. The cysts are pretty large. Do you ever get asymptomatic ones that you don't touch, you leave, and kind of monitor it, or do you always have to go take it out?
So in my part of the world, most patients present to me very late. So most of the time, that's why I have the pictures of these very large ones. But yes, it is possible to have them present very early. So for example, like if it's in the CP angle and maybe it's going into the internal acoustic canal, then they can present very early with subtle hearing losses. For those ones, usually then we watch them and monitor them, tell them there's the possibility that the tumor will grow. And it's usually a decision between the patient and the doctor. There is no clear-cut decision on when to intervene. But again, for the very small tumors, it may be easy to get out, but at times because of where it's insinuating itself, it's very difficult to access. And at times we have to just balance out and watch and wait, and then that's the only time when they have severe symptoms and we decide to intervene.
Strict monitoring. Rakesh, you have any questions or comments?
Nothing much. It was a nice presentation.
Okay, thank you. Thank you. Okay,
Thanks,
Dan, I think we'll let you get to sleep after the 36 hours of running straight. Thank you very much. Thanks for a great presentation, and we hope to have you back, and you're welcome anytime.
Definitely. Thanks, John. Sorry the presentation was a little bit short, but I just wanted to make it brief. I'm very honored to have been invited to be part of this series of lectures. And I'll just catch a quick nap, and hopefully I'll catch up the other presenters during the later times as the other presenters present. And hopefully I'll be there to chip in once or twice.
Okay. We look forward to it, Dan. Thank you very much.
Thank you.
Thanks, guys. Bye-bye. Take care.